Let's get started. It's my pleasure to welcome you all to today's Region 4 Project Echo session from the Emory University School of Medicine's Serious Communicable Diseases program, run in conjunction with the Southern Regional Disaster Response System and the National Emerging Special Pathogens Training and Education Center. My name is Gavin Harris. I'm an adult infectious diseases and critical care physician, the Director of Education and Outreach for our Serious Communicable Diseases program here at Emory, and your host for today. As always, before we begin, please know that we will be recording this session, and your data, while used for informative purposes, will be kept confidential. For those unfamiliar, ECHO is an acronym standing for Extension for Community Health Care Outcomes, founded by the University of New Mexico. It's designed to disseminate and amplify best practices in a collaborative and interactive manner. And if you're interested in participating in future sessions, please reach out to us. Details will be at the end and on our website. As always, if there are any issues during the webinar, please send us an email or type in the chat. And if you would like to ask a question during the session, please type it into the Q&A feature. We'll do our best to answer questions in real time, and we'll discuss as many questions live as we are able. If we don't get to all those questions, we will post a recap addressing those topics on our website when the recording to this session is available as a podcast next week. These sessions are accredited for continuing education credits by the AMA and the ANCC. Credit can be obtained for attendance upon completion of a survey at the end of the session. Importantly, the presenters and the planners of this session have no financial conflicts of interest with ineligible companies to disclose. And here's today's agenda. As always, we will start with the Region 4 SITREP, followed by our case and didactic presentations with a moderated Q&A to follow. And now it's my honor to introduce our guests for today. First, I'd like to welcome back Dr. Marshall Lyon, our case presenter for today. Dr. Lyon is Professor of Medicine at the Emory University School of Medicine and the Director of Transplant Infectious Diseases. He came to Emory after serving as a CDC Epidemic Intelligence Officer and has personally cared for Ebola patients as an original member of the Serious Communicable Diseases Unit clinical team here at Emory. In addition to this work, Dr. Lyon is very active in research into novel medical countermeasures for resistant pathogens and has authored over 90 publications, books, and book chapters. Next, I'd like to welcome back Dr. Anna Yaffee, Associate Professor of Emergency Medicine at Emory and Grady Memorial Hospital, and Emergency Medicine Liaison to the Serious Communicable Diseases Unit, or SCDU. Dr. Yaffee is also a nationally recognized subject matter expert in communicable diseases preparedness. She's the co-chair of the Adult Care Group for NETEC and the Director of Global Health and Emergency Medicine section at Emory. Lastly, Dr. Yaffee is a former lieutenant commander in the U.S. Public Health Service and has also worked as a CDC Epidemic Intelligence Officer. And lastly, I would like to welcome Ms. Liddy Varghese, Infectious Diseases Coordinator at the Georgia Department of Public Health. Ms. Varghese is responsible for Georgia's high-consequence infectious diseases preparedness planning, including managing the Georgia Infectious Diseases Network, which is a tiered system of healthcare facilities, and the dissemination of education. She's worked for many years in emergency preparedness, managing healthcare coalitions, working with partners of all backgrounds, and in streamlining communication and coordination. Welcome to you all. Now, to place this session in context, the Emory University Serious Communicable Diseases Program, in conjunction with the SRDRS, puts together situation reports on special pathogens of concern for our region, HHS Region 4. These SITREPs are published on our website, social media channels, Emory Department of Medicine YouTube channel, and various listservs. Here is the current HHS Region 4 Special Pathogen SITREP. We go first to Africa, to the DRC, or Democratic Republic of Congo, which has been experiencing an outbreak of Ebola virus disease since the 4th of September. On the 19th of October, the last Ebola patient receiving inpatient care was discharged, which marks the beginning of a 42-day countdown to declaring the outbreak over if no new cases are detected. The last new case was reported on the 25th of September. In sum, 64 cases have been reported, 53 of which are confirmed, with 43 fatalities. There have been 5 cases in healthcare workers, 3 of those fatal, and cases have also been reported in pregnant women and in children less than 12 months old. In good news, though, despite the rural location of the outbreak, a 32-bed Ebola treatment unit was constructed within days of the first confirmed case, and 35,000 people have been vaccinated within 6 weeks. Global spread risk is currently low. Next to Nigeria, where Lassa fever has been circulating since the beginning of this year. In the most recent report released on the 5th of October, there have been a total of 8,041 suspect and 924 confirmed cases, with 172 fatalities among those confirmed. While the number of suspect and confirmed cases has decreased compared to that report for the same period in 2024, the case fatality rate of 18.6% is significantly higher. Predominant affected age group remains the 21 to 30-year-old group, and as the dry season is coming in Nigeria, we do expect case counts to rise. Global spread risk is currently low to moderate. And now to mainland Asia and Pakistan, where on the 4th of October, the country reported the 6th confirmed fatality for Crimean Congo hemorrhagic fever, or CCHF. The latest case was a 28-year-old butcher admitted to a hospital on the 24th of September with fever, bloody vomit, and diarrhea, low blood pressure, and high heart rate, and who unfortunately died within a week. 5 of the 6 deaths this year have occurred in Pakistan's largest city in the south, Karachi. As the slaughter season is winding down, we are expecting a decline in cases worldwide, and global spread risk is currently low to moderate. Lastly, in Southeast Asia, Cambodia reported the 16th and 17th cases of H5N1 in the past 2 weeks, and the first cases since August. Last week, a 3-year-old girl was admitted to an intensive care unit following exposure to sick and dying poultry in the patient's home, and the most recent case announced on the 19th of October was in a 14-year-old girl who was also hospitalized. Notably, both cases involve a reassortment between an older H5N1 clade virus that has circulated for the past decade and the new clade virus that is currently circulating internationally. Global spread risk is currently low. And finally, there have been no reports of suspect or confirmed patients with special pathogens of concern in Region 4 at this time. For more resources, visit us on the web at scdp.emory.edu. And now, as always, before we delve into the main topic at hand, I did want to first pose some interactive poll questions to our audience to gauge our base comfort level with the topic. Those should be up on the screen, and if the audience could please vote now. The first question, how knowledgeable do you feel about the current Ebola virus disease outbreak? And number 2, how confident do you feel about implementing the identify, isolate, and inform process as it pertains to Ebola virus disease? Just a couple more seconds on this. And if we could get the results up on the screen, please. So for the first question, it looks like we have quite a range of spread of answers here, from not at all knowledgeable to a few people potentially being extremely knowledgeable. So I hope that this is an informative session on this. And then as it pertains to the identify, isolate, inform process, we also have quite a spread. So I do hope that our audience finds this engaging and educational. So with that, let me turn it over to Dr. Marshall Lyon for our first presentation, and we can begin.
All right. Thank you, Gavin. There we go, trying to get my camera to turn on. It is being finicky.
There we go.
Yeah. And okay, great. So this is, um, thank you for the sit rep, Gavin. I think that this case will be familiar to many people. It was a wake-up call to a lot of people about the possibility of disease spreading around the world in rapid fashion. So this is back in 2014, in September in Dallas, Texas, and a 41-year-old male presented to the emergency department of a community hospital there at Texas Health Presbyterian. So he had complaints of abdominal pain and nausea and headache, as you can see on the screen there. He spent 1 hour in the waiting room of the emergency department before seeing the triage nurse. The triage nurse got a temperature of, some might consider, a low-grade fever, still less than 38 degrees Celsius. And she noted in the electronic health record that he had just traveled from Africa. About an hour later, the ED physician examined the patient, noted some rhinorrhea and congestion, had some abdominal pain on examination, and recorded that the patient said he was from Dallas. And so during the ED visit, he was given a Tylenol for his temperature, his elevated temperature. He underwent a CT of the head and abdominal and pelvis. These were done. These were reported as, I would say, normal or unremarkable. His blood work at the time showed that he had a low white blood cell count. He had low platelets and an elevated creatinine and liver enzymes. Despite the acetaminophen, his temperature increased to 103 Fahrenheit during his hospital stay. So the 4 hours that he was in the emergency room, his heart rate also increased from 90 to 104 at discharge or just before discharge. And It was also noted that this emergency room and electronic health record had a SIRS response. It was an automated SIRS scoring system that they had in their emergency room. His SIRS score was 0 on admission, but during the course of his emergency room stay, he went up to a 3 with a maximum of 4. For whatever reason, this was not noted, and he was discharged home with some antibiotics with a diagnosis of an upper respiratory infection and sinusitis. 5 days later, on September 29th, 2014, EMS services were called to the patient's house. And EMS then reported back to the emergency room that the patient was having profuse vomiting and diarrhea. There were reports that, not in the medical record, but rumors, I guess, that there was unfortunately, there was a lot of soiling throughout the apartment, primarily in the bedroom where the patient had been staying there. They had a more detailed history that he was from Liberia. And on arrival to the emergency room, he was taken immediately to an isolation room, and PPP, or personal protective equipment use was implemented according to CDC guidance at the time. During this visit, he spent 30 hours in the emergency room in the isolation room with all staff following PPE guidance. The prolonged time in the emergency room was to allow for the hospital to clear out their medical intensive care unit of other patients, and so that he would be the only patient that was there in the MICU for care. During his time in the emergency room, he did get volume.
Marshall, we're able to see your slides and see your face on the screen.
I'm sorry, there was an announcement over. Sorry, Gavin, say that again.
I was just saying, are you having some technical difficulties? We're able to hear you, and see your slides.
Oh, there was an announcement, and I was worried that might be bleeding through. So it was very loud where I am. I guess it got muted out by the system. So sorry about that, everyone. Local public health and CDC were notified, and Ebola virus disease was confirmed. He had, despite ongoing ICU care, the patient did succumb to Ebola virus on the 9th of October in 2014. During his time in the ICU, it was noted that he had massive amounts of emesis and diarrhea. Staff identified that waste management was exceedingly challenging for them, given the volume of liquid waste that he was producing. And the other thing that they identified is that there was a PPE change. And this was actually in response to someone from Emory arriving on site to serve as a consultant. But the staff did comment that they felt unprepared for handling quite a sick patient. And then also having to undergo retraining with different types of PPE, albeit at a higher level. Unfortunately, as a result of this patient, 2 ICU nurses were infected, and shortly after being identified as infected with EBV or Ebola, they were transferred out of the Texas area. One came here to Emory, and the other one went to NIH for their ongoing care. So, I mean, I think, this episode served, as I mentioned, as a wake-up call, I think, to a lot of people, not only in public health, but also in government. There were some missed opportunities that were identified in a review of this episode. In the emergency room, there was felt to be a lack of verbal communication. So while the travel history from Africa was noted by the triage nurse, this was not verbally communicated, which at the time was an institutional protocol. It was part of their influenza screening process, not necessarily as a part of Ebola screening at the time. And then also, as I mentioned, there was this SIRS warning system, which was automated, that was either not recognized or not heeded during the emergency room visit number one. In the ICU, it was felt as self-reported by the staff that there was a lack of preparation in PPE and infection control training and waste management. There was at the time, it was felt the lack of adequate guidance from CDC. There was also a misunderstanding of what CDC and public health role was or would be in this sort of a situation. And then also at the time, there was a lack of a national system for serious communicable diseases that currently exists today and probably exists as a result of this episode. And with that, I will stop sharing and pass it off to, I think Dr. Yaffee is next.
Thank you, Dr. Lyon, for that excellent case report. As a frontline provider myself, every time I hear about that case, the patient presenting to the ED twice before being recognized as a person under investigation and then ultimately being diagnosed, definitely gives me chest pain. It makes me think about my own practice and my own emergency departments and how potentially easy it is to follow a Swiss cheese model and potentially have something similar happen. So hopefully through the next 15 minutes as we talk about identify, isolate, and inform, and then initiating care, we can give you some tools that are useful for everyone, regardless of your practice location or your role to implement to prevent something like this happening again. So, when I'm hearing this case, I'm thinking, what would I do if this patient presented to my facility? And I want you to be thinking about this as well. So, each of you know your facility the best, and so thinking about just kind of like what the intake and kind of what would happen should a patient like this present is really useful throughout this content. So we're going to be following the mantra of special pathogen preparedness, which is identify, isolate, and inform. When I say identify, I mean we are using signs, symptoms, and then epidemiologic risk for the patient to indicate the risk of having a high consequence infectious disease. And so the ability to identify or recognize these signs and symptoms is paramount in order to initiate the next steps in containment and care. Isolate, meaning promptly and effectively isolating these individuals who are suspected to have a high consequence infectious disease from both the general patient population as well as from your hospital staff. And then inform, meaning we want to use an algorithm to notify infection prevention, public health, and all the important parties involved to advise next steps. So let's delve into this a bit further. And I should say that a lot of this content is from a larger frontline course that NETEC has organized. So if this piques your interest, definitely check out further resources moving forward. So as we're thinking about identify, I want you to be thinking about points of entry at your facility. So patients do walk in through the ED, they may be dropped off, they may come by an ambulance, but what if they go to a clinic or come through an alternate method? Or is there an ability to identify these patients in all of the points of entry that you have? And then who or what is a patient going to come in contact with even before potentially talking to a triage provider? So I think about places where I've practiced, sometimes registration is the first point of contact, sometimes security if they go through a metal detector, an evolved machine, or even a valet even before they enter the facility. So thinking about all of those people who a patient may be in contact with even before they're able to be identified. Some easy, low-hanging fruit to help identify is actually through self-screening. So having signage at all of your points of entry, which enables patients to self-identify, is really useful to help protect some of those frontline personnel, like the valet, the security personnel, the registration. This signage should be really positioned prominently to be very visible. So at all the points of entry, very large, easily understood, using languages that are relevant in your community, but also maybe pictograms for people that have low literacy. And the pictogram should be easy to follow. And then having a mask, hand sanitizing station, things like that, that really enable patients to at least begin to identify and maybe begin their isolation procedures. And this is important regardless of what they have, right? So even if they don't have a high consequence infectious disease, you don't want the flu, COVID, RSV, any of those usual things spreading around your waiting rooms either. So this helps protect everybody regardless of what the patient ultimately has. When we move to gather further information, we want to be gathering information that assesses the patient's epidemiologic risk of having a serious communicable disease. So the gold standard would be using a universal symptom and then travel and exposure screen to do this. Ideally, working with your electronic medical record in order to better streamline this process and make it very routine. Every patient should be asked these questions, regardless of their chief complaint or their clinical situation, in order to better identify and isolate patients who could be at risk. So these questions include something like, do you have a new fever, cough, or rash? If a patient says yes to this, patient should be put in a mask. That's kind of your first isolation measure, regardless of what any of the next answers are. And then you're going to assess for their epidemiologic risk. So this could be something like historically we've asked about international travel, although now we know that even travel within our own country or regionally can also be risky, as well as other types of exposure. So when we think about things like H5N1, other things like that, we may want to incorporate what's going on in the world and in our region at that time. So any new travel, any new exposures, we use 21 days for viral hemorrhagic fever. Your facility may standardize that out to 30 just to be more universal. But either way, we want to be assessing those patients for epidemiologic risk. Now, we're asking a lot of triage providers. We can't expect triage providers to know everything that's going on in the world, like the situation report that Dr. Harris presented at the beginning of this presentation. But there are some useful tools that are available where triage personnel can go to assess if travel to a certain country or a certain location could be risky. So potentially your facility infection prevention team may be kind of updating you in real time. Many electronic medical records also have universal algorithm updates to kind of notify you if there is a risk. The local and state health department, the Georgia Department of Public Health has a really nice travel screener on their website that has a lot of updates of kind of what's going on in the world. And so that's a nice tool. NETEC also on their website has situational updates, and then the CDC and the WHO. So certainly if someone's concerned, they should delve a little bit further. Our next step after we identify a patient who may be at risk, so having symptoms plus an epidemiologic risk factor for a serious communicable disease, particularly in this context of viral hemorrhagic fever, we need to move towards isolating them. So ideally, this is in a isolation room with the appropriate transmission-based precautions, but we need to think about even steps before that. I know in my emergency departments, our isolation rooms are being used for other patients typically in the average day. And so we may need to prepare that isolation room. So where are you going to put your patient while you're waiting? You don't want to put them back in the waiting room. Maybe you have like an alternative triage space or an alternative room where they're separated from others where they can await that room. And then who's going to prepare the room? Who are you telling from triage onward about this patient? Is it charge nurse? Is it a designated provider? And using a checklist to help that person adequately prepare would be really helpful so that because this is a rare thing to practice for most staff. You also want to think about the designated route to the isolation room. So how are you going to get the patient from point A to the isolation room? What are they going to be passing? What kind of surfaces are involved? So for example, in this image, they're rolling over what looks like carpet, which would probably be very challenging to disinfect afterwards. So kind of taking some of those things into consideration, maybe using a containment wrap, particularly if the patient is demonstrating some wet symptoms, will be helpful to prevent spills along the way. We recommend using universal and transmission-based PPE and isolation precautions. And this PPE may not be something that your staff is terribly familiar with. That's something that was mentioned in the Dallas case where the nurses felt very unprepared with the PPE that they were using. And so having people who are super users in PPE, using trained observers, using just-in-time training options to get everybody up to speed in the appropriate PPE is really helpful so that they can adequately take care of a patient. When we're thinking about the preparation of the isolation room, we want to think about everything in that room. We typically in the emergency department have a lot of supplies that are at our disposal in each room so that we're prepared for every patient. But we may want to remove all those extra supplies because anything in that room will need to be discarded afterwards. And until that patient is confirmed or ruled out for a viral hemorrhagic fever, that material would all be category A waste. We want to make sure we have our PPE cart readily available, our hand hygiene stations are ready to go. If the patient has access to a commode or a private bathroom, that we have a lot of waste bins available. These patients generate a lot of waste because of all the PPE changes and the sanitizing that occurs. And then we want a log sheet for personnel monitoring so that we know who has entered the room. So this is just an example of kind of a before and after, kind of to pare down the room as much as we can. After we've moved the patient from the triage area to our isolation room, we want to start letting people know that we're dealing with a situation. We should never feel that we're alone. This is something that should be guided by our facilities infection prevention and control team, particularly our local and state public health, potentially your region's regional special pathogen treatment center. You also want to be thinking about who needs to know that this is going on in your hospital. So probably your departmental leadership, your hospital leadership, and then team members who may kind of be going into rooms and doing things that are kind of routinized in your care process. So environmental services, laboratory, phlebotomy, EKG, things like that. Making sure you have good signage as well to make sure that these people are protected. You're going to need security, and you may need your facilities public information officer to be involved to field any questions from the public if this is something that has any media presence. Who is going to be initiating this process? So as you're thinking about developing your facilities plan, it's important to think about who the roles are that are initiating Inform, the roles that are kind of doing the isolation process, things like that, so that it's a designated person and that there's no burdening of the care team. So we got our patient in the room, we've called our infection preventionist, public health is aware. Now what do we do? Well, we have to initiate care. So we can't just put a patient into the room and then wait for Emory or wait for public health to give us next guidance. In the emergency department, as physicians, we have ethical and moral obligations to our patients. We also have a legal obligation through the EMTALA mandate to care for our patient. But we should feel comfortable that we have the knowledge and tools in any frontline facility to safely and appropriately stabilize this patient. So we shouldn't feel scared to do that. If we're in appropriate PPE, we can really make a difference for this person. So I want to spend a moment looking at the viral hemorrhagic fever case definition. As you can see, it includes both elements of symptoms like fever, headache, fatigue, muscle pain, vomiting, diarrhea, and an epidemiologic risk factor within the 21 days. So to meet criteria for testing, a patient needs to meet both of these pieces of the case definition. But you'll note that those symptoms are very nonspecific. So when we looked at the clinical presentation of patients with Ebola in Guinea in the outbreak in 2014, you can see that the most common symptoms, fever, fatigue, diarrhea, headache, these were nonspecific. They were not bleeding, and the severity really depends on what point in their illness they were at. If I think about my ED right now, I probably have 50% of my waiting room with one of these symptoms. And so it really is important to gather really important epidemiologic risk historical data in order to determine who is actually a person we should be concerned about. The signs are also widely variable. So patients may have fever, tachycardia, they may be hypotensive, maybe a rash. Again, late stage is when bleeding, altered mental status, multi-system organ failure occurs. So we need to be paying attention to those early presenting signs earlier rather than later. It's also important to recognize that obviously other diagnoses are more common in our practice setup. So for example, malaria. Malaria is the most common cause of fever in returning travelers. Unfortunately, there's also a co-infection rate with patients who ultimately diagnosed with viral hemorrhagic fever. But you may be thinking about ways to rule in or out malaria. So if you have laboratory capabilities, doing things like blood smears, or at least the historical factors like cyclical fever, insect exposure, things like that. Sepsis. We heard that the patient in Dallas was meeting surge criteria. Again, early sepsis is presenting vaguely similar to the viral hemorrhagic fevers, fatigue, fevers, tachycardia, hypotension. We want to initiate a sepsis bundle just like we would for any other patient. So that's fluid resuscitation, antibiotics, and any critical care needs for that patient. The flu, again, similar fever, fatigue, headache. The flu may have respiratory symptoms as well. So again, another important point in the history to take. Traveler's diarrhea or acute gastroenteritis, same types of symptoms. Pregnancy, the list can go on. So remember your differential diagnosis as you're talking to your patient, as you're examining them. It's very important to take a accurate history because that's what's really going to establish whether or not the patient meets criteria. So where did they travel? What did they do? Who were they with? What type of symptoms are they having? What are symptoms that would point towards more of a differential diagnosis like the episodic fever and malaria, respiratory symptoms? Thinking about pediatrics, they may not present as classically as some of the adults do. And then in the physical exam, really important to be very careful and go back to our basic physical examination skills, knowing we may not have our radiology and our labs available to us for this patient in high-level isolation. So looking at markers of volume status like skin turgor, mucous membranes, their blood pressure, markers of organ failure like their neurologic exam, their respiratory exam, things like that. Electrolyte abnormalities like palpitations, arrhythmia, weakness, and any markers of a co-infection or something else from the differential. Early care for a suspect patient is essential in the emergency department. We know that the diagnosis is most likely not a viral hemorrhagic fever, but thinking about a viral hemorrhagic fever should not delay our care for any of these likely conditions. And we need to provide clinical care for our differential, even while testing is ongoing. And even if it is a viral hemorrhagic fever, these same clinical care initiatives are going to be what is going to save this patient's life. The case fatality rate is much lower in patients who get care in developed countries because of the ability to have aggressive supportive care. And these patients really are dying of things like hypovolemic shock and electrolyte abnormalities. So these are things that would be resuscitated with sepsis and other things regardless of the diagnosis. So let's treat the patient for malaria. Let's initiate our sepsis bundle. Let's fluid and electrolyte replete them. Consider respiratory viral antimicrobials, and then those early critical care interventions with aggressive supportive care if we're considering a viral hemorrhagic fever. As a very brief aside, we do have some Ebola virus disease specific therapeutics. So 2 FDA approved therapeutics for some EBD that's been caused by the Zaire strain. So 2 monoclonal antibodies, but no other approved treatments for disease that may be caused by other species of Ebola virus disease, although there are some investigational therapeutics. And there is also one FDA approved vaccine, again for Zaire strain. And so that is really relevant for people who are involved in an outbreak or may have an occupational risk of exposure. There are a lot of challenges, I'm sure, as we've gone through this, thinking about your own facility, it's really easy to think about some of these challenges. So we're going to be restricting access to a core group of providers. So you may be needing to do work that's typically not in your usual wheelhouse. So things like blood draws, vital signs, things like that, maybe you might be thrown into. It may be hard to take a history and physical while you're in the PPE. You may not have access to your imaging and labs because of the nature of the isolation. And then waste management is a huge problem. All waste is category A, needs to be stored that way until the patient is ruled out. So as you're working through your protocol, thinking about what kind of steps need to be taken at your facility, just think about what else might be a challenge to your specific clinical scenario. With that, I'm going to close and turn it over to my public health colleague.
Hi, thank you, Dr. Yaffee. I'm just going to share my screen. Okay, hopefully you all can see my presentation, the actual presentation slides. Thank you, Dr. Harris. Thank you once again for the opportunity to have public health at the table to talk about what our role is in cases of aviral hemorrhagic fever. I'm going to cover today what we have done in Georgia and what we are doing in Georgia to prepare for high consequence infectious diseases. So this is just an overview of my presentation. So let's start with the history of preparedness in Georgia. So with the 2014 Ebola outbreak, which Dr. Lyons mentioned was a wake-up call across the world for many healthcare facilities, that's also what started preparedness in our state. So the Ebola outbreak happened, and Georgia was in a unique position because there were patients coming, to Georgia. One, because we had Emory here, but also the potential for patients, with Atlanta being one of the 3 airports that was identified for travelers from West Africa to be redirected to. So our state leadership quickly realized the need for some kind of robust system that would be put in place to identify, to quarantine, to isolate, and to provide access to care. So several things happened in the immediate aftermath of that outbreak. One was that DPH leadership got together and created what is called the Georgia Infectious Disease Network, which at that time was a 3-tiered network of hospitals, with tier 1 being treatment facilities, tier 2 being assessment facilities, and tier 3 being all frontline facilities. And tier 1 and tier 2 facilities were designated by DPH. We also collaborated because we have Emory right here in our state. We collaborated with Emory on their response for the patients that they were receiving. And we used their expertise to create training and education that the state then provided to our healthcare partners. The state created the Ebola active monitoring system, which was used to track all travelers and contacts residing in the state of Georgia by doing daily check-ins for 21 days. All local districts received money because one of the things that happened after the Ebola outbreak was there was federal grants available to support preparedness efforts. So through those federal grants, local districts were able to hire Ebola response planners to create local disease response plans, to meet with ports of entry, so airports, seaports, to do just the statewide education of this disease, what people should be on the lookout for, what districts' plans will be if people are identified, in their jurisdiction as potentially having been exposed to Ebola. The state DPH also partnered with UGA and Emory to provide education. So it was a day-long seminar to all healthcare partners through the healthcare coalition system that is already established in Georgia. And so over 400 different organizations participated and received information and training on the Identify, Isolate, Inform protocol, and also were able to participate in a facilitated discussion on how they should identify and address and who they should call and things like that. So these preparedness efforts continued from basically 2015 through 2020 because there was funding for it and there was momentum behind it. Unfortunately, in 2020, a couple of things happened. One, the funding streams ended, but also COVID happened. So preparedness for high consequence infectious disease such as Ebola, sort of took a backseat because all our efforts were directed towards COVID. After COVID, though, we were able to regroup, and COVID also taught us a lot of lessons. So we kind of leaned into developing this program to be a better one than what we already had. And so we also learned that there's more than just one kind of disease out there that can be high consequence. So we rebranded from Ebola to high consequence infectious disease, which is common nomenclature now nationally. The state hired my role, which is the infectious disease coordinator role, whose dedicated task was to develop this program, manage the infectious disease network, and to increase our HCID planning. We did have a statewide highly infectious disease plan that was developed during COVID. We have since looked at that plan and updated it, to reflect the efforts that we have made in our state and to also broaden it to more diseases that are out there. We are currently working on a more specific concept of operations for the hospital network and the transportation network. And the idea behind this plan is that, regardless of who's at the state or who sits in what role, we wanted documentation of what expected actions should happen when public health is involved or notified of a high consequence infectious disease patient. How does that coordination work really? So we wanted to document that so that it's there for record and so that there's no confusion about how it should go. And we are also developing protocols and processes for redesignation of the facilities that were in the original infectious disease network, which was started in 2015. So this is what our infectious disease network looks like in Georgia right now. So it has two components. It has the infectious disease hospital network and the infectious disease transportation network. We did realign the hospital network to align with the levels of the National Special Pathogen System, which was created prior to and during the COVID pandemic. And so they have 4 levels in the NSPS system. And so we realigned our tiered system to match theirs. So we have our regional emerging special pathogen treatment centers, which are 2 hospitals here in the state of Georgia, Emory and Choa. We have 2 level 2 hospitals, which are treatment centers. We have 5 assessment centers, and then all other healthcare facilities are level 4. So I'm just going to briefly talk about the different things that we do to keep engagement and preparedness ready. So one of the things that we do with our infectious disease network is that we have quarterly meetings with our level 2 and level 3 and our RESPECT partners. And in these meetings, we cover any topics that they feel are gaps or they're planning for, or things that are lessons learned. And so you can see there's 3 pictures on the screen that just are looking at a different ensembles of PPE. So PPE, as was mentioned in the case presentation and the didactic presentation, can be a point of challenge. So we invited all of our facilities to bring their PPE ensembles and share what they're using so they could look at each other's and figure out, oh, this mask works better in this scenario, or this is how we have laid out our things. And so it was super useful for the facilities to see what other people were doing and to pick best practices. We rotate these meetings at our different treatment and assessment facilities. So that way we allow the hosting facility to talk about progress that they have been making, to talk about the plans and documents and resources they have been developing. How have they engaged their staff? What kind of training are they providing? Once again, with the goal of allowing other facilities to learn from each other. The idea is a very, it's not like they're all hospitals, but it's a very non-competitive space. We want everybody to learn from each other's experience. So we do those meetings quarterly. We also participate in any exercises that are happening either at the local level, facility level, regional, or national level. So here are just 2 examples. On the left is an exercise called Baby Driver 2.0 that happened at the end of last year with our Respect hospitals and 1 assessment facility hospital. And the scenario was a pregnant lady who came in who, was went through the identify, isolate, inform procedure or protocol and was found to be confirmed with a viral hemorrhagic fever, but she was pregnant and going into labor. And in here in Georgia, we have a adult respect and a pediatric respect. So after she had delivered the baby, the 2 of them had to be separated, one going to the pediatric hospital, one to the adult. And so that was a really interesting exercise of how that would be done in a scenario that's already complicated and how DPH would support. On the right is the international and national Tranquil passport exercise that was coordinated by ASPR and HHS about patients coming in from out of the country and traveling to several states in the United States and how they would be transported, what assets would be used, and how coordination of those assets would happen when you're going from state to state. We do try to develop resources for our providers. So as Dr. Yaffee was mentioning, the first line of defense against high consequence infectious disease is the identify, isolate, inform protocol. And so on the left is our screening tool that we have developed here at DPH that we have disseminated to our healthcare facilities so that they can have this, posted in their ED in places where triage is happening, so that the staff that are doing these that are doing triage and are talking to patients can have a visual reminder of what the steps are, what they should ask for, what they should consider. What you don't see on the screen, but is on the bottom part of that screening tool, is a bullet point list of questions that our medical epidemiologists from DPH would want information on if you were to call DPH to inform us that you potentially have somebody of concern in your ED. So, it's a reminder of, did you ask what kind of exposures they have, exact travel dates, what all did they do while they were traveling? Have you considered other differential diagnoses? Have you done any lab testing, or have you given for any lab testing? What are your capabilities? So they have pointers on this screening tool for facilities to consider. We also have on the right is a magnet. It's meant to be a magnet. We've created it and we're going to use some funding to print it and distribute it. Once again, to just have it placed, commonly around hospitals so that somebody can look at it and go, yes, I know I have to inform somebody, but I don't remember the phone number. So hopefully this magnet is handy it has the phone number right there, or you can scan the QR code to get to the travel clinical assistant, which was the tool Dr. Yaffee was mentioning that Georgia Department of Public Health has, which is a website that shows you all ongoing outbreaks in all the different parts of the world. We have several Plan B resources, which are just things that we keep on hand in case one of our facilities in Georgia might need it. So we have Category A waste management kits. As we heard, waste management is a huge challenge with HCID patients. And so we have 16 kits that facilities can request if they are dealing with a patient that has a confirmed HCI or is high risk for an HCID that we can deploy. We also, though we don't ever want to use these, we also have decedent management kits, which are basically, it's a body bag system that could be used to safely package human remains if somebody with a confirmed HCID dies at your facility. And then they need to be transported to a different facility or to the mortuary, etc. We are working on increased visibility because while this system exists and has existed for a while, it's not helpful if people don't know that it exists and what we do and how to find out about us and what resources we provide. So in the past year, we created web pages on the Georgia Department of Public Health website and on websites that our healthcare coalitions use so that people can hear about us, read about the work that we do, how to get involved if healthcare facilities want to join the network, and also have access to the resources that we have developed and will continue to develop. And then something that's always happening is building relationships to address gaps, because we have gaps and some of them we cannot address on our own. So, disease management planning. What happens if somebody or multiple people in the state of Georgia confirmed to have an ACID, then die? Who do we work with? We know what happens in the hospital, but what happens after you leave the hospital? Who are our partners? So we did talk to our colleagues in Iowa after their experience with Lassa fever last year, and we learned lessons from them. And we have taken those lessons and we're trying to build those relationships ahead of time here in Georgia. So if we ever find ourselves in that position, that we know the people that we need to reach out to and what we would need to do. Some of the gaps and challenges that we have is, as Dr. Yaffee mentioned, identify, isolate, inform is the most important thing. And so we're constantly trying to provide ongoing education about that. And we have examples of facilities that do it really well. As soon as they have something that is concerning in their ED, they call 1-866-PUB-HEALTH and they ask to speak to a med epidemiologist. And most likely it is nothing, but it's still helpful because our med epi is able to help them talk through things. And then sometimes there are situations where the calls have not been made and the patients have been transferred from one facility to another before somebody thought to make that phone call to DPH. So that is always an ongoing challenge that we try to address. And then we have questions of, issues that we know exist, but we're not sure who's responsible for it. So it's like a whose lane is this kind of issue. So as Dr. Lyon was mentioning with the case in Texas, when you walked into that patient's home, it was highly contaminated. And so if that was to happen here in Georgia, whose responsibility would it be to decontaminate private belongings or living spaces of a patient? Because then that's obviously a risk to the community, to people living in and around that area. So it has to be decontaminated, but whose responsibility is it? Who pays for it? Just those are questions we are grappling with. This is also a lesson we learned from our Iowa colleagues. Sustained source of funding for hospitals and EMS is always a challenge. Hopefully there's good news on that front coming up soon. And then how to, maintain engagement, because as I said, preparedness in Georgia started in 2015, but based on what else is happening in the state and in the healthcare landscape, sometimes this is at the forefront and sometimes this is not. When there's an outbreak happening somewhere and it's in the news, people are thinking about it, and then sometimes people are not thinking about it. So to maintain that engagement for something that is low probability but high risk it's important but also challenging. And then lastly, our challenge is to have more facilities in the state of Georgia so that there is access to level 2 and level 3 facilities across the state. Currently, our level 2 and level 3 facilities are concentrated either in the northern part of the state, in the metro area, or one or other border of the state. But we have a huge part of the southern state, a huge southern part of the state that does not have easy access to a treatment or assessment facility. So that's a gap we would like to address. And lastly, our goals for the future. We've made a lot of progress in the last couple of years, but we still have more to do. As we have developed all the new plans and procedures and new resources, we want to continue providing education to our stakeholders and partners. So we are planning statewide seminars and maybe traveling to our healthcare coalitions to talk about what plans exist at the state, regional, and federal level, and what our processes are. We do want to complete a redesignation of our current infectious disease network facilities in alignment with the new NSPS criteria that has been established nationally. To that end, we're working on building an online platform that facilities could basically fill out their designation application by filling out how they meet the designation criteria and provide documentation for all of those that we would then approve and follow up with a site visit to then credential them. Good news is that, with H5N1 funding coming through our state some states have been allowed to use that funding to redesignate and support level 3 assessment centers. So our state will be doing that. There's also the NETEC STAND Award for special pathogen treatment facilities, level 2 treatment facilities that facilities can apply for. So we've encouraged our treatment facilities to apply for that award so that they can use that funding to be better prepared. We would also be focusing on recruiting new facilities, as I said, to address the gap in coverage in our state. And then because we have developed so many new plans and processes, our goal once we redesignate and have new partners onboarded is to exercise our goals and see our plans rather and see that they work in the way that we envision them to work. I think that's all I have, but I'm happy to take questions later on. Thank you so much.
Thank you so much, all of our panelists, for those excellent presentations. I am going to ask everyone to turn their cameras on. And I know we are a bit short of time, but there are a few questions that I want to make sure we get to. And so we may run over time, just as a notice to our audience. Again, the entire recording of this will be made available next week. We have on the line as well Dr. Anish Mehta, who is one of the principal investigators of NETEC and also a member of the NSPS Core Advisory Group Committee. And I wanted to turn to him first because several questions in the chat have come up, which I believe actually are quite related. And one of those has to do with the significant strain on hospital systems that events such as a patient with an HCID can unfortunately encounter. And so, Dr. Mehta, from your standpoint, looking from a strategic level, how might the NSPS relate to this, or how might this potentially alleviate some of the strain that hospitals and various parts of our region and beyond might be experiencing?
Yeah, thank you, Dr. Harris. So the goal of the NSPS is to really recapitulate the tiered system as described by our public health colleagues, Dr. Liddy Varghese. The expectation is that all hospitals be able to rapidly identify, isolate, and inform the public health and other structures around them to get the patient in the most appropriate arena for care while delivering the care that they can do at that moment. I think it is unattainable to expect every hospital in the United States to be able to care for a patient with a viral hemorrhagic fever for the duration of care. And therefore, we've tried to remake this tiered system where the patients can be identified and then rapidly moved to a place where they can be assessed. They can work with public health to get testing done, and those are called our level 3 facilities. And then if they are highly likely or confirmed to have a hemorrhagic fever or a novel pathogen that requires high-level isolation units, then they can move to a level 2 or level 1 facility by dedicated transport. We're lucky here in Georgia to have the IDN that can help us with that. But other states have done similar systems so that we get patients into care, we move them to the most appropriate setting, and then have them cared for in a setting where not only they can get the highest level care, but we know that we can sustain protection for our healthcare workers over time. That allows the rest of our healthcare system around us to continue to care for all the thousands of patients that come to our doors every single day without really missing a beat. And so it's good for our special pathogen patients, but really optimal for all the other patients in our system.
Thank you so much. I think a couple things I heard you say. One is that, this network is really designed to provide support to healthcare facilities throughout the country with the support of these 13 regional centers. And then the other I heard you say at the end there's truly no patient safety without staff safety, to just briefly summarize. Thank you so much for those insights. I'm now going to turn to Dr. Yaffee. We heard you mention a lot about identifying these patients and then also the initiation of care. We also know from previous studies that, from initial diagnosis to initiation of treatment, mortality increases by at least 11% in patients with filovirus infections. But I think the simple fact of the matter, and one of the concerns from several people in the audience, is the operational impact of a PUI or suspect case or a confirmed case in the emergency room. And so I was wondering if you could just provide some short thoughts on lessons that you've learned and maybe some opportunities for improvement in this realm.
Yeah, I mean, there's no question that this is going to cause you an operational strain for sure. Our emergency departments are already understaffed, overcrowded, and this having a patient kind of requiring this amount of care with personnel and PPE and kind of a dedicated area certainly will impact your flow. But we also want to be protective of our staff and our other patients, and so it's definitely the right thing to do. I think that some of the things that can help address some of this is really having a very strong protocol in place and making sure that you have designated roles for each of the aspects of the protocol so that everybody knows what they're supposed to do, who's stepping in to fill their previous role if they're being taken out of kind of the general patient care flow, and kind of so that that is more streamlined. And then drilling that, I think, is really important. Every time we've drilled, we learn so many new things about even like the physical layout and how to get a patient from point A to point B and kind of what gaps are left behind. That will be really useful to you as you are developing your protocols.
Thank you so much, Dr. Lyon. From your perspective in your review of what has happened, in Texas and also in your experience in caring for these patients, what are your thoughts kind of on the same perspective as to, how can we preserve, throughput and business continuity while also understanding and recognizing the strain on hospitals that this level of care needs?
Well, I mean, I think that many of the things that have been put in place that through NETAC and departments of public health have made it easier for normal operations to continue, because what that has done is it has identified a team and individuals who will be responsible and will take care of these high consequence pathogens, allow them to do their work, sort of cordon them off in a place, have places already identified. And then that allows the rest of the hospital to more or less, not always, but function under sort of routine conditions. And I think, that's been one of the biggest things. I mean, as was mentioned, as funding was running out as we approached 2020, there were a lot of lessons that have been learned and things put in place for Ebola that when we got to the pandemic, it was, I feel like many places were much better prepared to handle that. I think the problem with the COVID pandemic is it was just so overwhelming on so many fronts, that it was nearly impossible for a lot of places to conduct business as usual because of the burden of patients that we're on.
Appreciate that perspective, Dr. Lyon. Okay, Ms. Varghese, from a public health perspective, in light of what we've just been talking about with the recognized strain on hospitals, from your public health lens, have there been discussions or thoughts to innovative approaches for potentially alleviating some of that pressure, either through telehealth monitoring or home quarantine of patients, or anything else that potentially DPH here in Georgia has been thinking about?
I think we've had some discussions about, telehealth monitoring. I think the most important thing is just to be aware that even if a hospital is addressing a concerned patient, that the first thing they need to do is call 1-866 Pub Health, because it may not need to go any further than necessary. If you make that first phone call, get that med epi on the line with you to help you talk through what potential concerns are, because we've had times where, you're concerned and then you're immediately looking to, okay, let's get this patient transferred to another hospital. Let's get EMS on the road. Let's get this patient going to the next level of treatment. And that does add strain to what you're already doing in your facility. But if you can get public health and the med epi on the line with you to help you talk through those initial steps and make that consultation, then that will help alleviate some of that initial stress. Telehealth is something we have talked about, but we don't actually have viable options for right now, but that's always something that we are open to if we can carry out in a sustainable manner.
Appreciate that perspective, and also your perspective with 1-866 Pub Health. Of course, each state in our region is going to be slightly different. So just to highlight that, it would be important to know the protocols and processes for the states of which our guests are part of. We are about 5 minutes over time, so I am going to have to stop us there. We will get to some of the questions that have been posted, but we did not get to next week. I want to thank our audience very much for their participation. I also want to thank our panelists and presenters. We do have one more poll question that we will put up on the screen right now, and that is, after going through this session, how knowledgeable now do you feel about the current preparedness approaches surrounding Ebola virus disease on that same scale that we saw before? Once again, post-session resources, including podcast visual recordings of the webinar, presentation slides, and our responses will be available next week. If we could please put the results of that poll up on the screen as well. And it looks like our panelists have made significant inroads, so I do want to highlight this and also extend my sincere thanks to all. Thank you to our Project Echo team here at Emory with Yasmin Thornton and Allison Claybar, among others. Certificate of attendance is available upon completing the survey here. We hope to see you again soon. Take care and stay safe.